Can you hear me clearly? I said, Dr. Barni.
Yes, sir, I can hear you, sir.
Very good. So there's no interruption, right? Very good. I'm good to start as soon as you say go.
Okay. So, good evening, everyone. Welcome to today's YMO mentor class. And today's topic is molecular testing in endometrial cancer and its clinical implications. So, it is my privilege to introduce today a distinguished leader in the field of medical oncology, Dr. Senthil Rajappa, sir, whom we have today as our speaker. He is the head of the Department of Medical Oncology at Basavatarakam Indo-American Cancer Hospital and Research Institute, Hyderabad, with over 28 years of experience. Sir has been at the forefront of cancer care in India, known for his clinical acumen, compassionate patient care, and commitment to advancing oncology practice. He has completed his DM in medical oncology from the prestigious Kidwai Memorial Institute of Oncology, Bangalore, and he has also previously served as an associate professor in the Department of Medical Oncology at Nizam's Institute of Medical Sciences, Hyderabad. Now, Sir is widely respected for his evidence based approach, multidisciplinary collaboration, and leadership in clinical research, and his contributions extend beyond the clinic. He is a much sought after speaker at national and international forums, and he is widely popular for his engaging and impactful lectures, and he is actively involved in oncology education and policy. So I think sir needs no new introduction. So without wasting any further time, I will request sir to begin today's session. Over to you, sir.
Thank you very much, Barnini, for the very generous introduction. You're telling me things that I don't know about myself. Anyway, thanks so much for that. Good evening, everybody. Uh, so, when I was contacted upon and asked for what topic you would like to speak upon, I thought I'll talk upon something that is kind of becoming an enigma for everybody. Everybody seems to be having some difficulty navigating through molecular testing and its application in endometrial cancer. So I thought I will take this up and then try to make it as simple and as clear as possible because I myself don't understand too much of these complicated issues. So I'll try and tell you what little I have understood and see how we can then move forward with this knowledge. So today's topic is molecular testing in endometrial cancer. Cancer is missing from this title and its clinical relevance. So today we will only talk about the relevance of molecular testing in localized disease because that is a topic in itself. We will not talk about markers that we may do additionally in advanced disease. If we have some time, we can maybe talk about that. Life was very simple in endometrial cancer. You know, when I was a student, there was hardly any treatment. Most people after surgery would get radiation or no treatment because endometrial cancer was regarded as a disease which has got excellent prognosis. Still, most patients continue to have very good prognosis. So life was very easy. We used to put together anatomy, which is TNM staging, pathology, and come to very simple treatment related conclusions. But ever since the time that the affair between anatomy and molecular biology started, and then now they seem to be wedded forever, things started becoming much more difficult. And the course of this talk, we will try to navigate through those difficulties and clear things up for our clinical management. So let's start with this patient case. This is a 64-year-old lady who underwent staging surgery for endometrial cancer. Her histopathology shows a grade 3 is high grade endometrioid adenocarcinoma involving more than 50% of the myometrium, no lymphovascular space invasion. Her nodes are negative, so she is stage 2C. She's stage 2C based on the FIGO 2023. If she was stage based on FIGO 2009, she would be 1B. What adjuvant therapy would you offer for this lady? Should it be vaginal brachytherapy? Should it be chemotherapy only? Should it be chemoradiation therapy? Should it be pelvic radiation therapy? So there are multiple options for this lady. Let's start with some very basic questions, which is which sample do you use for testing and what do you test for? So, whenever somebody asks you this question, the ideal sample to test is always the initial biopsy that they have taken from the endometrium. You don't do it on the surgical specimen if you can avoid doing that. Okay. Now, why do we say this? Because when you do surgery, many times the surgery is done many parts of the day, so the samples don't get transported to the pathology lab on time. So the fixation times are not adequate. There is deamination, and all these tests are suboptimal when they are done on tissues that are not fixed adequately and appropriately. On the other hand, when you do an endometrial biopsy, the diagnostic biopsy that you get, that is more likely to be of better quality to do all your tests rather than the surgical specimen. And that's the reason we would prefer doing it on the initial biopsy. It's not that you don't or cannot do it on the surgical specimen. I'm just talking to you about a preference that we would have. What do you test for? I think that's what the rest of this talk will be all about. Now, this is the TCGA molecular subtypes of endometrial cancer. If you're not able to, really comprehend anything that's on the screen, don't worry, I'll take you through that. You've got four broad categories. One is the pole E, the next is MSI. You've got a copy number low and a copy number high. Okay. Now, this pole E or polymerase epsilon, which is the expansion for pole, is the rarest of the molecular abnormalities that you get in endometrial cancer. You also refer to this as ultra mutated. Now, what does the term ultra mutated mean? We always look for TMB in our molecular profiling report. So we call TMB high when the mutations per megabase is more than 10. Now, in an ultra mutated tissue, you would find that the mutations per megabase are 100 or more. Now, that's an arbitrary cutoff just for you to understand. If it's very high, now what is very high? 100 or more is very high. That is called ultra mutated. The next is microsatellite unstable or MMR deficient, which is called hypermutated because the TMB is also high in this subtype. And then you've got a copy number low. We'll come to that in a moment. And then the copy number high. The other abnormality that you see in the screen consistently is the P10. Okay, P10 is associated with good prognosis in endometrial cancer. Okay, P10 is associated with good prognosis. That is why you will find that most of the pole E subtype associated with good prognosis has P10, while the right extreme, which is showing you the worst subtype of endometrial cancer, hardly has any P10 alteration at all. Okay, so we learned what is pole E, we've learned what is ultra mutated, we've said P10 is associated with good prognosis. It's present in the majority of the pole E mutated ones. It's rarely associated with the copy number high or the serous like. How did they get to this classification? It's very complicated. They did whole genome sequencing, whole exome sequencing, proteomics, and all the things that you and me generally don't understand. So let's leave TCGA alone and then get to something much more simple that you and me can do in our hospitals. Now we are getting to TCGA based surrogate. That means this will represent what the TCGA classification is in the majority of times. All of us are experts in MMR, right? Mismatch repair. We do immunohistochemistry for four proteins: MLH1, PMS2, MSH2, and MSH6. That is the standard way of looking for MMR. You can also stain for P53. It's not perfect surrogates for a P53 mutation, but in the majority of times, there's concordance between mutation that you get on a PCR or NGS versus what you get on immunohistochemistry. We'll come to all of this in greater detail as we go by. Pole E, we spoke about this in the previous slide. A couple of points that I want to make here. When you do an NGS for a pole E mutation, you will find a pole E mutation in nearly 30% or more, right? The more sensitive your NGS, the more depth you sequence, the more pole E mutations you're likely to pick up. But remember that I said that this is the rarest mutation and happens in less than 10%. Now, why is this less than 10%? Because all of these mutations are not pathogenic. You've got only 11 pole E mutations that we will classify as pathogenic. And only if you have one of these 11 on a PCR or an NGS, then you will call it as pole E mutated, or its mutation in the exonuclease domain. So let me say that again. All pole E mutations are not pathogenic. You've got a list of 11 mutations which are pathogenic. Only if you have one of these 11 mutations in the method that you're used to testing, you will call this as a pole E mutated endometrial cancer. Okay, this is very important to keep in mind because we're moving to NGS. NGS can pick up umpteen number of pole E mutations, the majority of which are not likely to be pathogenic. So if you do MMR, if you do P53, and if you do a pole E, either by PCR or an NGS, you can then put endometrial cancer into four broad categories. One is the pole E mutated one, if you have one of the 11, or if you have an abnormal mismatch repair or an MMR deficient, then that's called an MMR deficient endometrial cancer, or if you have no poly mutation, MMR is proficient, the P53 is wild type. I call this the triple negative endometrial cancer. That's called no specific mutational profile, or NSMP. Okay, all the three are negative. That's called NSMP. If the P53 is abnormally expressed or not expressed, then that's called a P53 mutated or a P53 abnormal endometrial cancer. So you're putting these into four different compartments based on three different alterations that you're trying to pick up: POLE, MMR, P53. If one of this is present, you put it into that category. If none of these are mutated or all of them are wild type, all the triple negative, you call that the non-specific mutational profile. So these are the four broad categories that you know that in endometrial cancer. Now, if you take 100 endometrial cancers that would walk into your clinic, the majority of them are endometrioid, 83%. If you split them into these molecular categories, we go back to the TCGA, you will see that the rarest is pole, 7%. The next is the copy number high, which is the serous carcinoma or the P53 mutated one. The next would be MSI or MMR deficient. The fourth and the fourth will be the non-specific mutational profile, which is the most common subtype or the most common molecular subtype. So the least common is pole, the most common is non-specific molecular profile or non-specific mutational profile or copy number low. Now, which has got the best prognosis? Pole has got the best prognosis. So you see the blue line being standard. Almost none of them will get their disease back. Which is the worst? The copy number high is the worst, or P53 mutated. That's the worst kind of endometrial cancer you can have. The other two fall somewhere in between, with the MMR deficient one having slightly better prognosis compared to the non-specific molecular or mutational profile. So the best is pole, the worst is P53. In between, you have NSMP and the MMR deficient. The MMR deficient has a slightly better prognosis compared to the the non-specific molecular profile would. So that's how you would get these molecular subtypes in terms of their distribution in endometrial cancer. Now, here we start getting into the specifics of each one of these molecular subtypes. We start with IHC for P53. We said this is something that we can do in all our labs. So, this is something that we need to learn well. Now, don't concentrate on the left side of your slide. Start from the right side of your slide. Now, what is normal P53 expression? Remember, P53 is the guardian of the genome. Where does the genome stay? It stays in the nucleus. So, where should you see P53 expression? You should see it in the nucleus. Variable nuclear expression in less than 50% cells. Okay, so that is normal P53. Variable expression in less than 50% of all cells. What are the abnormal P53 expressions that you can have? That's what you're seeing on the left. One is mutant overexpression. That means you have nuclear staining, but it's there in more than 50%. It's usually in the 80% plus range. So that is abnormal. It's there in the nucleus, but most of the cells seem to be expressing P53. So this is abnormal. The second is you're not seeing any P53 at all. That is also abnormal. So extensive is abnormal. Not seeing any staining is also abnormal. Then you can have cytoplasmic staining. Remember, we said P53 is the guardian of the genome, so it should be there in the nucleus. But instead of being there in the nucleus, if it is seen in the cytoplasm, that is also abnormal. So these three will have a pathogenic P53 mutation. Okay, so in the lab, if your pathologist says that it's overexpressed, not expressed, cytoplasmic expressed, then you will say that this is a P53 mutant endometrial cancer. Now look at D. D is showing some strong expression and many areas that are weak. So this is called a subclonal P53. But remember that subclonal P53 is not commonly associated with a pathogenic P53 mutation. It is frequently associated with a pole or MMR deficient. Okay? So a subclonal P53 expression is not an abnormal pathogenic mutated P53. It's more often associated with the good prognosis one. So that's why you're calling it subclonal. Here it is not pathogenic. Okay? So extreme is pathogenic, which means extensive expression, no expression. Both of these are pathogenic. You then have cytoplasmic, which is pathogenic. You have some strong, some weak, that is more often associated with a better prognosis one. So this is how you read P53 abnormality in the lab on immunohistochemistry. What's the concordance between IHC and NGS is 95% plus. So that's good enough for us to use IHC as a surrogate one. We then move to MMR, right? We said we check for four proteins by immunohistochemistry. MSH2 and MSH6 form a pair. MLH1 and PMS2 form another pair. Okay, so we always test in pairs. But the question is, can you test only for two of them? Yes. In resource constrained settings, you can just test for MSH6 and PMS2. Why is it that we are seeing this? Because almost always, if MHS6 is lost, then MSH2 will also be lost. If PMS2 is lost, MLH1 will also be lost because you need MSH6 and PMS2 for MSH2 and MLH1 to be expressed. Okay, so if you are in a resource constrained setting, it seems to be okay most of the time to just test for two proteins rather than four proteins, but ideally we'll do four. Which is the best method to do this in endometrial cancer? IHC is the best method to do this in endometrial cancer. Why should you be doing this? Because it's diagnostic for endometrial adenocarcinoma. Okay, endometrial carcinoma, it's diagnostic because 20 to 40% tend to carry MMR deficient mutations. It's also used for screening for Lynch syndrome. So if you have an MMR deficient endometrial cancer, then it is important to screen that family for Lynch syndrome. We already said it's prognostic, which means patients who have MMR deficient endometrial cancer do well. It's predictive for the action of sensitivity to immune checkpoint inhibitors. So, if you have an MMR deficient endometrioid adenocarcinoma, those patients are likely to be sensitive to immune checkpoint inhibitors. So, this is why you test for MMR in endometrial cancer. Now, what is the discordance between PCR, which is the other method that you use to test? It's about 6% discordance, so not very high. We'll not get into MLH1 promoter methylation for today. We'll leave it for the discussion of some other day. Okay, so the ideal way to test is IHC, ideally four proteins. If you're resource constrained, two proteins are fine. You've got four reasons why you test for MMR: diagnostic, screening for Lynch, prognostic, predictive for the sensitivity to immune checkpoint inhibitors. There's good concordance between IHC and PCR, which is the other method. Now let's get into the science a little more. We use MMR deficiency and microsatellite instability as interchangeable. Now, when do you use microsatellite instability as a term? If you're using a PCR in order to test for MSI. Okay. So, what is MSI, microsatellite instability? So, let's start by asking the question, what are these microsatellites? The microsatellites are nothing but short segment DNA, which is there in all of us. Okay? Now, if this exceeds a particular length or number, then you call it as microsatellite instable or unstable. Now, what does this reflect? If you're not able to repair the genetic mutations that are happening in the cell, if you have an abnormal repair mechanism or your repair mechanism is non functional, you tend to accumulate these microsatellites. If you're able to clear these abnormal mutations, you will not accumulate microsatellites. So, you can accumulate microsatellites both in terms of number and in terms of the length of these microsatellites. So, what you do in PCR, you check for five microsatellite proteins or segments. I'm sorry, it's not a protein, for five microsatellite DNA segments. So you've got BAT, DS, don't let's not get into that. That's not for today again. So you choose five microsatellites that you're checking for. If you've got loss of expression of these microsatellites, that means you're clearing all these defects. So if you don't have one or more, then it's called a deficient MMR, which is something similar to the MMR deficiency that you're talking about. Okay? So of the four proteins, if you've got loss of one or more, this is by IHC, this is not by PCR, then you call it deficient MMR. If you have all the four proteins that are expressed, you call it as a proficient MMR. We've still not come to PCR. Hang on. One or more lost, it's deficient. All preserved, it's proficient. So this is by IHC. So if you have unclear results, that means your results are not, clearly saying it's lost or all are preserved. All the four are lost sometimes. Sometimes three, sometimes one. So sometimes these are not clear. So when these are not clear, you end up needing to do a PCR. What do you look for in a PCR? You look for altered lengths of these particular segments that you're trying to detect. If 30% of the segments that you're trying to look for in the PCR are altered, okay, why am I saying 30%? Because some of these PCRs for MSI look for 8, some look for 13. So it depends upon the number of segments. If 30% or more are altered, you call that as a MSI high. That means if you're looking for five, if two or more of these five segments are altered, then you are calling this as an MSI high endometrioid adenocarcinoma. If there are all of them are preserved the way they should be, very similar to what you get in normal tissue, right? Then you call that as MSS. If only one is altered, you call that as MSI low. Okay, let me say this again. You're choosing five segments or DNA segments that you want to detect. You compare it with normal tumor tissue for the number and length. If you've got a longer or an altered one, and 30% of them are altered, you call that as MSI high. If all of them are preserved very similar to normal tissue, then you call it as MSS or stable. If only one. So you can also call this based on the number or call this based on the percentage of altered segment. Okay. This is how you do an MSI by PCR. If you have abnormal or unclear results, rather than saying it abnormal, we will call it as unclear results on the IHC. Now, before we move to the next one, we all have patients with MMR deficient endometrial cancer, but not all of them respond the same way to immune checkpoint inhibitors. Not all of them have the same good prognosis. Sometimes you have an MMR deficiency, but those patients suddenly relapse very quickly. Why does this happen? Because MMR deficiency now we realize is not one group. You can have an MMR deficiency because of an epigenetic mechanism, which is promoter methylation. You may have a TMB that is normal with an MMR deficiency. You may have a CPS that is not high with an MMR deficiency. Secondary alterations can alter the sensitivity of this to immune checkpoint inhibitors and impact prognosis. The microenvironment now we know is extremely important. So though we are clubbing all of this into one, remember that this is not one disease, this is a heterogeneous group. The prognosis and the sensitivity to immune checkpoint inhibitors can be very, very different depending upon the other associations with MMR deficiency. So, now let's put all of this together again and go through the classification. So we start with a pole mutant. If the pole E is mutated, 11 of those pathogenic mutations only, not every single pole mutation, you call it pole endometrial cancer or pole E mutated endometrioid adenocarcinoma. If your MMR is deficient, you call it MMR deficiency or MSI high endometrial cancer. If your P53 is mutant, you call it P53 endometrial cancer. If all the three are wild type, you call it non-specific mutation or no specific molecular profile. Now, why are these listed in this particular sequence? This is called as a promise classification. Now, if you've got a pole mutant, that is the subtype that it will belong to. You probably don't even need to test the rest of them. If you've got an MSI high, then that's where it will fall into. You may decide to or not test the rest of them. If you've got pole that is Y type and MMR that is proficient, then you may decide to do P53 because then if P53 is not mutant, you will call that as no specific or non-specific mutational or molecular profile. Okay, so that's the sequence in which you test. It's something like an hierarchical testing. So pole, MMR, P53, all the three are wild type. You call it no specific or non-specific mutational or molecular profiling. So that's the sequence in which you do these tests. You don't say, okay, I want to first test P53. If P53 is mutated, it's bad, so let me stop there. No. If a poly mutant is going to be there in a P53, it behaves like a poly mutant, not like a P53. We'll come to multiple classifiers in a moment. Now we will add one more small variable to this classification, which is whether this no specific molecular profile has expression of estrogen receptor or not. Now we have come to realize that if you have a non-specific molecular profile or no specific molecular profile, we initially said the outcome is very similar or slightly inferior compared to an MMR deficient endometrial cancer. Now that holds good if your ER is positive. If your ER is negative in an NSMP, then your prognosis is going to be very close to what it is if your tumor was a P53 mutant one. So very likely in the future classifications, you will have one more category of NSMP or a totally different category, which is NSMP ER negative, wherein the prognosis is going to be very close or similar to a TP53 rather than an NSMP or an MMR deficient endometrial cancer. Okay, this is to show you that an ER negative NSMP has poorer prognosis compared to if the ER was positive. You see that the Kaplan-Meier curve is showing that the recurrence-free survival is inferior for the same NSMP if the ER is negative. Okay, so this is important to keep in mind. If your ER and PR both are positive, that seems to be the best. Okay? But we would generally test for ER only. We don't test for PR in early cancers at least. Now, let's get to the histological subtypes and ask ourselves what alterations are you likely to see in each one of these? Remember, endometrial cancer grade 1 and 2 together is low grade. Endometrial cancer grade 3 is high grade. Okay, so this is important to keep in mind. So if you're low grade, you're likely to be NSMP or MMR deficient. Okay, NSMP or MMR deficient. If it's grade 3, you could have one of the four categories, and here is where molecular subclassification has maximum utility. Serous, almost always, 90% of serous carcinomas, you would get a P53 that is abnormal. Clear cell, paradoxically, is NSMP. You would expect P53. That's not typically the abnormality that you'll get in the clear cell, though the prognosis is poor. In mixed ones, serous, P53. In undifferentiated ones, it's MMR deficient, it's not P53. In carcinosarcoma, it's P53. So histologically, if you see a carcinosarcoma, you're more likely to see a P53 mutant. Histologically, if you're seeing an endometrioid low-grade carcinoma, you're more likely to see an NSMP or an MMR deficient endometrial cancer. Okay, so you try to put the histology and the molecular together and see how good the correlation is. If the correlation is not good, you go back to your molecular pathologist, you go back to your, regular pathologist, if you can call them that way, and then ask, look, guys, this is not getting together. Would you want to go back and check if what you're saying is right or now? We did go through this. We'll quickly run through this once again. If it is low grade, most of the time it is likely to be an NSMP or MMR deficient. That's what you're seeing in this slide. Most are associated with good prognosis. Most of them are early stage, and the impact of molecular testing on therapy is quite low in this subcategory. Okay, so if you're in a resource constrained setting, you don't have the wherewithal to do even IHC testing. If you've got an early stage endometrioid grade 1 or 2, which is low grade carcinoma, it may be okay not to test because you're getting a very small percentage of patients that will be a copy number high. You see that 8% in grade 2 and a very minuscule 1 or 2% in grade 1. So you're going to misclassify a small percentage. That's okay in a resource constrained setting, but wherever it is, all need to be tested. What about the utility in a higher grade carcinoma? The maximum utility will be in high grade endometrioid because there you have a wide split. And that is where it is going to impact your prognosis and treatment maximally. Remember, we started by saying our patient has got a
પછી આપણે બે લેતા આવશું એની તરફ
our patient has got a 2C or a high grade.
લેતા આવશો ને મળતો આવશું
Okay, okay. Somebody is talking there. Let's cool them.
સાડા
Okay, so okay, you're kind of
Please mute yourselves, everyone.
thank you. So we started our case as 2C, which is high grade endometrioid carcinoma. That is where your molecular testing has got maximal utility. When you come to the end of this talk, I'll show you how it can move between multiple risk groups depending upon what the molecular testing is. So if you're asking the exam, where is it that you would like to maximally employ molecular testing? It's in the high grade endometrioid. Okay, so that's an answer for you. So some caveats. As we said, it's most important in high grade histologies. You tease out the good prognostic ones in the high grade endometrial cancer because if you've got a high grade endometrioid cancer and you've got a poly that's mutated, it moves into a very good risk category. If you've got an MMR deficient, because most MMR deficient endometrial cancers are high grade endometrioid ones. So, based on the grade, you don't start giving them chemotherapy and radiotherapy. It might actually move to a lower risk. P53 mutation in low grade endometrioid cancers is extremely rare. And if you're finding one, think of a series with glandular differentiation. Okay, this prognosis will be not as good as what you get in a low grade cancer. Pol E or MMR deficiency in serous is very uncommon. Okay, a poly mutation or an MMR deficiency in a serous is uncommon. What do you get in a serous? You get P53. But if you get a poly or an MMRD, think of endometrioid carcinoma. So here is where I said you go back to your pathologist, you go back to your molecular, pathologist, ask them what it is, ask them to recheck have they reported it rightly because your molecular and your histology is not going hand in hand. What do you do if multiple ones are mutated? That means we said clearly poly or P53 or MMR deficient or none. Okay, but life is not that easy, isn't it? In a small percentage, you may have more than one alteration. So you can have poly plus an MMRD, a poly plus P53, and MMRD plus P53. So if you get something like this, how do you classify? Remember, we spoke about the promise that if you get a poly mutated, that's what takes precedence. That's what your classification will be, even if you have a P53 that is abnormal, because most of the P53 that comes along with the poly is a subclonal non-pathogenic P53. So a poly will trump both MMR deficient. So if you have a poly and an MMR deficient, you will call it a polymutated endometrioid adenocarcinoma or an endometrial carcinoma because the prognosis is very similar to a polymutated one, not similar to MMR deficiency or a P53. We said pole is the first test. Next, you will test for MMR deficiency. If you've got an MMR deficiency and a P53 abnormality, it's not a P53 mutated one. The outcome is likely to be similar to MMR deficient one, and your approach to treatment will be like an MMR deficient one, not like a P53 abnormal one. So, pole is the highest. MMR deficiency comes next. P53 comes next. All the three are not there. That is no specific molecular profile. So if you've got multiple classifiers, that is the hierarchy. Pole first, MMR next, P53 next, and then no specific molecular profile. So that's how you put multiple classifiers into a compartment. You can't say you got the prognosis similar to poly and P53. That cannot happen. Okay. So that's how you deal with multiple classifiers. As we are testing more, as we are doing more NGS, we are finding more multiple classifiers. So remember, again and again, I'm saying this, poly, only 11 pathogenic mutations are there. If you do NGS for poly and P53, you'll find that your multiple classifier rate will go to somewhere around 20%. That's wrong. That's not the right way of doing things. You have to have your pathogenic pole E exonuclease domain mutation, that's exon 9 mutation. Okay, so that's very, very important to keep in mind when you're interpreting your molecular report. So, guys, after spending so much of time with basic sciences, let's get to the clinic. Now, wake up if you're already getting bored. So you put morphology and molecular together and get to FIGO 2023 from 2009. And we've also got some ESGO guidelines that have been published very, very recently. It's available to access. I can put it in the group later for all of you to go through. It's a very nice, concise paper. Okay, don't go through this, don't try to read what I've written here. So 2009, 14 years later, 2023. We are using molecular abnormalities to also assign stage. So if you got somebody with a stage 1 and 2, but with a poly mutation, they are not stage 2, they will be 1A. Okay, 1A is the best group. So you've got a stage 1 and 2 with a poly mutation, they are not stage 1 and 2, that is 1A. So if you've got a 1C with a poly, that becomes 1A, it's not 1C. If you've got a A3 with a poly mutation, you will make it 1A1. It is going to be as good as that. Aggressive histology with any myometrial invasion or a P53 mutant, 1 becomes 2C. Okay, if you were classifying this aggressive, so let's say it was in 2009, 1B, that means 50% or more myometrial invasion, it's high grade, then you don't call it 1B based on the 2009. If it's high grade or if it's a P53 mutant, from 1B, it migrates to 2C. Okay, so 2C, all early high grade tumors will become 2C. or if there is a p53 mutation, they become 2C. So we're using molecular characteristics to also reclassify these patients on the TNM or the FIGO staging. I'm sorry, this is not TNM staging, on the FIGO staging. So stage 1 and 2 with a poly mutant will become 1A. Aggressive histologies, even if it is stage 1A, it'll become 2C if you have a high grade histology or a p53 that is mutant. So that's how you're using. Now, you put all of this together and put them into molecular categories. This slide is not meant to be read, so don't try to do this. Okay? I'm trying to say that by using your FIGO stage and molecular characteristic, you put them into various risk categories. Okay? What are these risk categories? You've got low risk, intermediate, high, intermediate, and high. How did they get to this group? It is based on the 5-year risk of recurrence. Less than 8, 8 to 15, 15 to 25, more than 25. Okay? Less than 8, 8 to 15, 15 to 25, more than 25. How does this help you to treat patients better? If you've got low risk, you don't need any further treatment after good surgery. If it's intermediate or high intermediate, it is between adjuvant brachytherapy only or pelvic external beam radiotherapy. If it's high risk or if the risk of recurrence is more than 25%, so it's chemotherapy for sure. Some patients might warrant radiation therapy. Do we really know how much of chemotherapy, how much of radiation should we ideally be doing for these patients based on the characteristics? We really don't know. But some general caveats. Radiation brings down the risk of local recurrence. So the GOG studies, almost 5-year follow-up, shows that there is no improvement in the overall survival for the addition of radiation therapy to high-risk group. So some of us would end up doing 4 cycles of paclitaxel plus pelvic radiation. Some would do just 6 cycles of paclitaxel. These are both fine. As you increase the number of chemotherapies, the less likely that you will be able to effectively complete your external beam radiation therapy for want of because of toxicity. Okay, so if you're planning to do EBRT and chemo, cut down your chemotherapy to 4 cycles rather than 6 cycles. After 6 cycles, you may at best be able to do adequate brachytherapy. So, what to do, how much to do, I think is a discussion that you should have in your tumor board and with your patient, putting together what are those factors that put this patient at a high risk of local recurrence versus systemic recurrence. If you find some factors that may also be predictive of local recurrence, we really don't have some overarching factor that will tell us, no, for this patient, you should definitely do radiation. There's nothing like that. So it's putting everything together and then deciding what you want to do for your patient. Again, very complicated one. I'm using this in order to illustrate one particular factor. Remember, we started with our 2C patient, high grade. How is it that molecular is going to really help you categorize this patient? Now, look at this. If you have the same patient with a poly mutation, it becomes low risk. If you have the same patient, no LVSI, but your MMR is deficient, it becomes intermediate. Same patient, MMR deficient, but substantial lymphovascular invasion of your cervix is involved, that becomes high intermediate. And if there's no MMR deficiency and there is no pole mutation, they immediately get to the high risk. Okay? Same stage 2C, high grade endometrial carcinoma. By doing your molecular profiling, look at how it can go from low to high with just these 3 tests that you can simply do in your lab by immunohistochemistry and adequately treat your patients. One important thing, what are the gray areas in this? There are a couple of groups of patients where you are still saying, I don't know exactly what the prognosis of this patient is, and treatment decisions have to be taken on a case by case basis. So, if you have a tumor that is just confined to the endometrium or just a polyp with a p53 mutant, we said p53 mutant is bad. But if you've just got a tumor that's confined to the endometrium or just a polyp, we think it may fit into the low risk category and we may not need any treatment at all. But are we confident about saying this? Probably not. Similarly, stage 3 and 4 molecular does not have much value beyond saying that you may have sensitivity to immune checkpoint inhibitor or screening for a Lynch syndrome, etc. But if you have a stage 3 or 4 with a mutated pole, then again, we just don't know where this patient falls because poly mutation, excellent prognosis. But if you got a poly mutation, which is stage 3 or stage 4, because stage 3, stage 4 FIGO has poor prognosis generally, and we would do chemo for all these patients, we would add radiation for at least some of these patients. So if you have a stage 3 or 4 with a mutated pole, gray area. If you got the other extreme, a tumor that's confined only to the endometrium or a polyp with a bad mutation. So these two extremes, I think, still remain gray areas. We just don't know where they fit in and how to treat them. Again, case by case basis. Putting all of this together, if you've been sleeping all the while, if you've been bored all the while, if you've been eating all the while, it doesn't matter. Just concentrate for the next 30 seconds. Why should we test? The elementary question. Because it's prognostic. You can put them into various risk groups. It's predictive because based on the risk groups, you're going to treat them and you're going to improve outcome. As we said, optimal therapy, predictive for immune checkpoint inhibitor if you have an MMR deficient or a poly mutation. If you get an MMR deficient, then you may want to look for germline mutation in that patient. Okay, so that's why we should test. What markers to test for? I'm just talking about localized disease, poly, P53, MMR, estrogen receptor. When do we test? At diagnosis. What sample do we use? We said the initial biopsy sample wherever feasible. But if that is not feasible, then it's okay to do on a surgical specimen. But we spoke about why we prefer an initial biopsy sample compared to a surgical specimen. What methods do we use? IHC for P53, MMR, estrogen receptor, PCR for pole, and MSI if your MMR testing is not very conclusive. And of course, we are moving to NGS because that's kind of an all in one test. Where is the maximum impact? The intermediate risk and the grade 3 disease. I gave you an example of how in grade 3 disease, the disease or the patient can migrate from one risk group to the other based on the presence or absence of mutations. What happens with multiple classifiers? If you got a pole, it's poly. If you got an MMR, you got MMR. Okay. If it's a pole and an MMR, it's poly. Okay. So it's poly, MMR, P53, and then the no specific molecular profile. Come on, what do we do with these results? Stage risk stratify. We said low, intermediate, and high. Low is less than 8% recurrence at 5 years. Intermediate is 8 to 14, 15 to 25. More than 25 is high. Why do you stratify? Because in some patients you can observe. In the intermediate, you give brachytherapy only. In the high intermediate, it's pelvic radiation therapy. In the high risk, it's chemotherapy plus minus radiation therapy. In stage 3 and stage 4, if you've got an MMR deficient disease, apart from the chemotherapy, you've got the option of adding an immune checkpoint inhibitor also, because now we know that the relapse-free survival is better when you add an immune checkpoint inhibitor compared to if you don't. So that's why you risk stratify and then treat. And then finally, what to watch out for? More confusion because we are testing more, we are learning more. If you learn more, you're more confused. So we will leave at that and take questions if there are any at this point in time. We will stop there. But Nini, are there any questions? Okay, so let me go to the chat box. I'm seeing some. Okay, so let's start with. Okay, external beam plus vaginal brachytherapy, that's very, very selectively done. It's very, very selectively. Okay, typically external beam radiation therapy is done if your nodal staging is inadequate or if you have extensive lymphovascular invasion. Okay? Vaginal brachytherapy is typically done if there is lower segment involvement. But I said that if you're doing chemotherapy, then the value of external beam radiation plus vaginal brachytherapy would be more to bring down the risk of recurrence rather than improve overall survival. So you should use it very selectively. Okay, it's rare today that we use both of these in the same patient. Isn't tumor heterogeneity more represented in post-op specimen? You are right, or you may be right, but we're not going to check 5 blocks from the post-op specimen and do molecular testing in all the 5 blocks, right? In reality, you're going to get 1 block and then look at that. If you're talking about heterogeneity in terms of the histology, maybe you're right, but not necessarily in terms of molecular testing. Preferring, okay, is for endometrium or all other malignancies. Okay, good question. So, in all other malignancies, we would prefer the diagnostic biopsy rather than the surgical for the same reason that I said. Is copy number high same as NSMP? No. Copy number low is NSMP. Copy number high is typically P53 mutated, right? It's the high grade ones that are P53 mutated, the undifferentiated ones who are wild for MSI. These are the ones which are copy number. Copy number low is NSMP. Copy number high is the P53 mutated. Copy number high is okay. Somebody has answered that question. Factors saying high risk for local progression. So we said risk for systemic progression. Okay, risk for systemic progression is where you're likely to have liver metastasis or peritoneal recurrence. That's what I mean when I say distant metastasis. When I say local, I'm talking about a pelvic recurrence or a vaginal vault recurrence. So these are local. Wherever your lymphovascular invasion is not extensive, wherever your lymph node dissection is adequate, the likelihood of benefit from any form of local therapy is going to be very small. And even if they have a local recurrence, it's either going to be associated with extensive peritoneal disease or systemic disease, or you're likely to be able to salvage that localized disease. So that's the reason why we really are not very much in favor of doing, external beam radiation therapy after chemotherapy. But we're not doing chemotherapy. We spoke about intermediate or the intermediate high. There is a value for doing brachytherapy alone or external beam radiotherapy. We do IHC or NGS. When do we do PCR? So if you're doing sequential testing, the test that you use for a pole mutation is PCR. You can't do pole by IHC. Okay, so IHC is used only for P53 and MMR and ER. For a poly mutation, you have to do a PCR or an NGS. Okay, so that's it. Is P53 null means that none of the cells are staining for nuclear P53. So that is what is P53 null. So if none of them are staining, that means it is P53 mutated. Okay. As per promise, we should look for pole first, but sequencing takes more time. Yes, so you're absolutely right that in reality we end up doing parallel parallel processing rather than waiting for one and then doing the other. But I just told that for you to understand that in terms of hierarchy, where does this fall into as a category? So it's pole, it's MMRD, but you're absolutely right that in reality we don't do one after the other. So promise doesn't seem so practical in terms of turnaround time. It's absolutely practical. It's just that you're going to do all at the same time, not one after the other. So that's how it becomes practical. Like stage grouping in 9th AJCC breast, are we supposed to memorize? Okay, please don't memorize. Please keep it, on your table. And if you're finding a patient with a particular molecular testing and if he goes stage, you put it together and then decide. Don't ask me how will you do that in the exam. You broadly need to know where what patient will fall, and then say that in the exam. Most of the time, your examiners are also not likely to know exactly where the risk categorization can be. Why does NCCN? Lovely question. You put me in a spot. Okay, so NCCN in my mind is a little delayed I would prefer to treat it like the ESGO or the ESMO recommendation rather than the NCCN, because NCCN is waiting for more prospective randomized evidence. It's going to take a long time for us to get prospective randomized evidence. So, in that slide, I said ambispective data. So, part of this data based on which the ESGO has made recommendation is retrospective, part of them is prospective. So, I think for me, we need to move on. I don't think it is appropriate to be sitting on waiting for evidence to happen. We know it's bad prognosis. We need to treat them better. We've got some evidence that treating them better with more aggressive means is likely to improve outcomes. The role of endocrine therapy in high grade EC as maintenance. No, we don't do it. Typically, it's rare to find ER expression in high grade endometrial cancers. Even if you find an expression, it is unlikely to respond to estrogen receptor therapy. Why tamoxifen is recommended in EC when it is a positive. So we just don't know which is the best one. You could use medroxyprogesterone, you could use an AI, you could use tamoxifen, you could use alternating medroxyprogesterone and tamoxifen. We just don't know which is the best. Okay, so it's not that tamoxifen is the recommended one. Tamoxifen is one of the many recommended endometrial cancer hormone therapies. Okay, so do you do lymph node sampling or systematic lymphadenectomy? If your lymph nodes are not enlarged, you typically do a sentinel lymph node biopsy and then proceed based on that. Lymphadenectomy has not been shown to improve overall outcomes, so most of the time it is sampling or a sentinel lymph node biopsy and proceed. In the molecular era, is there any relevance to type 1 and type 2? I think broadly, from a histological standpoint, yes, it is. But you ultimately put morphology, you put stage, and you put the molecular together and then decide where your disease falls. So it's like asking, in ovarian cancer also, there's a type 1, type 2, do we use? We don't. But for broad classification, I think it still holds some relevance. I think we've answered the next question. Someone else is sharing the screen. The issue was there only for a few seconds. When to consider CTRT versus RT alone in high intermediate, majority of the times it's pelvic radiation therapy. We don't do chemotherapy, right? So that's how it is. But if you decide to do chemotherapy, it's typically in a situation where you're doubtful about your P53 and so on and so forth, or there's extensive LVSI, plus there is lower uterine segment involvement, and all of these, you may be tempted to do chemo, but in the majority of situations, we would only do external beam radiotherapy. Role of adjuvant chemotherapy in high risk MMR deficient. So, if it's high risk MMR deficient, it would typically be a stage 3, stage 4. Okay, so if you're saying high risk MMR deficiency, it's stage 3, stage 4. So, there you would use chemotherapy plus an immune checkpoint inhibitor as adjuvant therapy. In all other categories, if the MMR, if it's stage 1 or 2 with MMR deficiency, it would either fall into the low, intermediate, or the high intermediate, depending upon the grade. Okay, so that's how you differentiate. How to integrate classical prognostic markers along with molecular testing in deciding? I think we just know to decide based on whatever little we have at this point in time. There are other markers which also confer prognosis like LCAM and so on and so forth. I think in the future, as we understand these better, we will be able to integrate this better and subclassify this further, but we'll only add to the confusion. But for me, at this point in time, whatever we have here is for me good enough to make the decisions in most of these patients. Do we have data for amount of benefit with different therapies? So we have some retrospective data and some prospective data, but I think we are moving on with whatever data we have based on prognosis. We don't have high quality prospective data to substantiate everything that the ESCO actually has said. Can we avoid chemo? Yes, we probably can. This has to be a very nuanced decision because I said if it is stage 3, it stage away falls into high risk. And if you have high risk and pole ultra mutated, you're probably in a gray area where we don't know what the prognosis is likely to be. So I would then take in all the other factors. I may look at what's the lymphocytic infiltration. Is the TMB also high, really Is it really a pole ultra mutated patient? I would look at the age, I would look at other prognostic factors. So we put all of these together and then probably make a decision rather than just putting stage and your pole ultra mutated together to make a decision. Any role of PIK3 mutations? No, not at this point in time in early disease. How will you differentiate ovarian versus endometrial, endometrioid carcinoma? It is very difficult to do that, especially in very early stages. So, if an endometrial biopsy has it, then you clearly will say this is what it is, but it can be a difficulty sometimes. Can we avoid RT also based on the pole E? Yes, if you've got a pole E, stage 1 and 2, they automatically become 1A and there is no need for any further treatment at all. Stage 1, grade 1, NSMP, ER strong positive, lymph nodes not dissected, we would typically ask them to go and get a lymph node dissection done. We would ask them to go and get a lymph node dissection done because that is going to make a huge difference in terms of what you're going to do. If your lymph nodes are dissected, they are negative, this patient does not need any treatment. If your lymph nodes are dissected and this is positive, then you probably need, depending upon whether it's the pelvic or the parietic lymph node, need a lot of treatment. So in our hospital, we would put this patient to a sentinel lymph node biopsy or a lymph node dissection and then only take a call on what we should be doing. Uh, what do you do in the clinic? European approach. Yes, I am a European approach man, but nothing wrong in holding on till the Americans also say we shouldn't be listening to the Americans, okay, for various reasons. Role of adjuvant therapy in DMMR tumors? Yes. High risk patients warrant immunotherapy for your year. What's your take on adjuvant chemotherapy? Bernini, you tell me when to stop. I'm just going on and on and on. What's your take on adjuvant chemotherapy in NSMP? I would treat them like a P53 mutant, so you would not have an intermediate risk group in that. So if you have an NSMP ER negative, that would move into a high risk straight away and needs to be handled like a high risk patient. When ICI is used as adjuvant with chemo or alone with chemo in the high risk category, high intermediate risk with substantial LVSI, external beam radiotherapy. Do we have data for the amount of benefit? No, we've already answered that question. Should we consider adjuvant treatment based on molecular markers only versus local factors? I think ultimately medicine is putting everything together. There are no watertight compartments. There are no this criteria only, that criteria only, this is the one, that is the one. I think we should move away from this compartmentalization paradigm and look at everything as a spectrum and put patients somewhere in the spectrum. Look at a composite risk rather than a single risk and then make your decisions rather than basing your decisions based on only one factor. High intermediate substantial, okay, we did that. 1C EC with P53, gray area. We just really don't know what to do with that patient. In our hospital, we would typically observe that patient. For inadequate lymph node dissection or no lymph node dissection cases, do we still need? I think as much as possible, you would go and dissect. And if you can't do, then it's external beam radiotherapy plus minus chemotherapy, depending upon the grade and molecular. ER testing is only important for the NSMP group. Typically, yes. High risk stage 3 DMMR. No, we don't talk about HER2 today. We only talk about DMMR if we have a high risk patient, it's DMMR, so it's chemo plus an immune checkpoint inhibitor. HER2 does not have any role in early disease. What sequencing in advanced carcinoma endometrium? Is it sandwich? Okay, we used to do sandwich in our hospital. We then found that patients end up very finding it very difficult to come back and do their chemo after the radiation therapy, especially if it's external beam radiation therapy. So we typically tend to complete all the chemotherapy and then send them for external beam radiotherapy. In some patients during the external beam radiotherapy, we skip the cisplatin that's given week 1 and 4, depending upon tolerance, etc. Sometimes patients come with pole E mutation, analysis, P50 mutation, PCR. In such cases, okay, if you really want a WAF cutoff, it's 10%. Thanks for this excellent talk. Very good. Role of adjuvant chemotherapy in high risk MMR deficient patients. I think we've answered this. MMR deficient, a chemo resistant, you are absolutely correct. And the prognosis is also good, but we don't have evidence to just do immune checkpoint inhibitor as of now. So we are doing chemo plus an immune checkpoint inhibitor. How do you decide when to give sequential. We spoke about this. Inadequate dissection, extensive LVSI, radiation has a role. Otherwise, radiation has a very small role. Treatment will be as per POTEC 3 protocol, POTEC or the GOG, whichever you are comfortable with. ICI, we spoke about this. Stage 3 and 4 CPI adjuvant, we spoke about this. How to differentiate, we spoke about this. Here we use WTN1, which is more likely, if you ask our pathologists, they will always say, this can be positive in that, that can be positive in this, and will end up only confusing us more. Okay, we seem to have gone through all these questions also. I'm feeling hungry now. So I'm sure all of you are also feeling hungry. So, Varnini?
Thank you, sir, for the wonderful session. Sir, I got logged out in between due to unstable internet connection. So, sir, I think the students have benefited a lot from today's class because we have all been reading the FIGO 2023 staging. And also for the students, memorizing it in itself is difficult, but understanding the clinical implication, I think, sir, that is actually the most important part of it. So when you had decided to take this class, I myself had felt so happy because I thought that this was a much needed topic. So thank you very much, sir, for taking your time out and dedicating it for the YMO mentor class, sir.
Sure,
Thank you.
Varnini, thanks so much. I enjoyed. I learned so much as I prepared for this. So I hope all of you also enjoyed it. Looks like it. Anyway, thanks so much, and then we'll call it a day. Bye bye. Good night.
Good night, sir. That we are ending today's
Yeah,
session,
yeah,
sir.
sure.